Good afternoon, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist, professor and vice chair of the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team working in communities across Georgia. It is also my pleasure to be host for Emory's COVID-19 Facebook Live events to keep everyone up to date on the COVID-19 pandemic. Today, I am pleased to be joined by Dr. Carlos Del Rio, a face all of you know. Dr. Del Rio is a distinguished professor of medicine, epidemiology, and global health at Emory, and is the executive associate dean of Emory's School of Medicine at Grady Health System. Dr. Del Rio is also the co-director of Emory Center for AIDS Research, known as CFAR, and the foreign secretary of National Academy of Medicine. As an infectious disease physician, he is an expert in COVID-19 and is also an investigator in Moderna's clinical trial for COVID-19 vaccine. Good afternoon, Dr. Del Rio, and thank you for joining me again today.
Delighted to be with you, Dr. Guest.
Thank you. So let's spend a moment on some COVID-19 numbers from this week. The US remains one of the hottest countries in the world for COVID-19 cases, with 22% of the world's cases in 4% of the world's population. The US now has 14 million cases of COVID-19. We have had more than 4 million cases just in the month of November. India, the country with the second highest case count, has a population that is 2.4 times bigger than the US, with only 66% of the cases we have had. A month ago, we set new daily record with 83,000 cases diagnosed in one day. Yesterday, 195,000 cases were diagnosed and more than 2,700 deaths. 100,000 people are currently hospitalized with COVID-19 in the United States, more than double than what we saw a month ago, and approximately 20% of all hospital beds currently hold a COVID-19 patient. While the pattern of this pandemic has been clear, infections go up, hospitalization rates follow in a few weeks, and deaths spike. These increasing case numbers, while we are seeing spikes in hospitalizations and deaths, mean we are nowhere near the peak of what we're going to see with COVID-19, the way we are currently trying to control it. So Dr. Del Rio, the last time we talked on Facebook Live, we were discussing the need for CDC to regain their role and their voice in the efforts to control the pandemic. In the past 2 days, we've seen that happen with the new quarantine recommendations and publicly held forum on Tuesday, where a panel discussed and then agreed upon the first groups to receive the COVID-19 vaccine. So let's start there today with our conversation. Let's start with the changes in the quarantine guidelines. The changes moved the quarantine time from exposure date from 14 days to 7 days if you have a negative COVID-19 test on day 7 or 10 days without a test. So what are the data behind this, and what are your thoughts about these changes for quarantines?
Well, first of all, let me start by saying that these changes are very much welcome. Many of us have been talking about it for quite some time, and it's good that CDC has finally moved this. Telling people to quarantine for 14 days really made no sense based on what we know about transmission of this virus, the things we've learned lately, et cetera. But it did not take advantage of having testing available. And if you can get tested, like if you had an exposure and you can quarantine for 7 days, and then on day 7 you can be tested, you're pretty much free. You pretty much have no chance of developing disease. So you will be able to then cut your quarantine time in half. If you don't have access to testing, then you need to quarantine for 10 days instead of 14 days, but that even is a significant change from before. So I'm very much think that this may actually increase the compliance of people with quarantine, and it makes me think that it's a way to give people options. And I think it's very important to tell people that here are your options, and this is how you can use them more effectively.
Wonderful. We certainly need people to be accepting of the quarantine recommendations. So I agree with you. I think that these are a great positive step. Now let's move for a second to the other thing the CDC has been talking about a lot this week, which is who should get the vaccine first. Very exciting that we've got 2 vaccines up for emergency use authorization from the FDA, and that review will be starting next week. So CDC met yesterday, and not unexpected, they suggested that the first people that needed to receive the vaccine were both healthcare workers and those living in and working in long-term care facilities. Can we talk some more about those groups?
Well, let's start first by talking about November. And November, as you said, was a horrible month. It's a month that we had 4 million new infections diagnosed in our country. That's almost, 1 million a week. We went 9 months to diagnose, before we got there, and now in a month we have 4 million infections. It's just an incredible number. But the other thing that did happen in November, that's the bad thing. The good thing is that every Monday in November we seem to wake up and hear good news about a vaccine. The first Monday was Pfizer, the second Monday was Moderna, the third Monday was AstraZeneca, and the fourth Monday was again Moderna. And I think all of us have been just thrilled to hear the results. I mean, the vaccines look much better than we predicted. We predicted about a 60% efficacy. We thought 60% would be very, very, very good. We have a flu vaccine that has about a 50% efficacy. So 60% was fantastic. And what we're seeing is 90+% efficacies, which really is hitting out of the park. Now, let's talk a little bit about what these vaccines do. At this point in time, what we know about these vaccines is that they prevent severe disease, and in particular, severe disease. So really what the vaccines will help us do is they will help us decrease hospitalizations and deaths. And that to me is a critical thing to do at this point in time, that, as you say, hospitals are getting overrun by COVID-19 patients and deaths. Yesterday we hit almost 3,000 deaths. That's one 9/11 in one day as a result of COVID. So we are seeing a huge increase in deaths. And I think if we can get the vaccine to bring that down, that will be very important. So then you get to the recommendations of the advisory committee. Who do you vaccinate first? Well, you start with healthcare workers, because those are the people that right now you need the most. The one thing that hospitals are struggling with is personnel. I can build more ICU beds, I can buy more equipment, but surge capacity is about space, stuff, and staff. And I can create space, I can buy stuff, but I cannot buy staff. Staff is a limited resource. So you got to protect your stuff and your staff. And if you remember in March, April, we were seeing in New York nurses and doctors from California and Texas go to New York to help out. Right now, when you have the problem throughout the country, you're not going to be able to do that. So protecting the healthcare workers and making sure they don't get sick and they don't die, it's a critical component to try to ensure that we have the capacity to take care of people. Then you move to the long-term care facilities. The highest risk of dying from this disease is in older individuals, particularly if you're over 60, over 70, and definitely over 80. Over 80, your mortality is about 30%. So if you can move into individuals at high risk because they live in long-term care facilities, the older individuals, and it's not only them, but also the people taking care of them, then you can dramatically decrease mortality. So I see that the first goal of vaccination is decreasing mortality in our country, is decreasing severe disease in our country. We don't know yet if this vaccines decrease transmission. We don't know yet if this vaccines decrease acquisition. And that's why when I get the vaccine, I'm going to continue wearing my mask. I'm going to continue socially distancing. I'm going to continue avoiding crowds, because the vaccine is not a license to not wear my mask. The vaccine is simply a way to prevent me, if I get infected, from getting sick and dying.
Wonderful. Thank you for making sure that we're talking about this with continuing to use our public health prevention messages, which are going to be so incredibly important as we move through this next year, where we're going to see more people vaccinated. Let's move for a moment to the idea of a national strategy. There has not really been one with COVID-19 in the United States. What do you think we need to see from a national strategy, or do you think we need one?
Well, I think we desperately need a national strategy. I think our biggest failure as a country is not having a national strategy. We have had state plans. I don't even think we have state strategies. The plans have been made on a day-to-day basis. And the reality is you can't fight a war with 50 different strategies and 50 different armies. That's not how you win. And the US right now is losing. We have to recognize that losing is because we have not had a national strategy. And I'm very optimistic that the incoming Biden administration, with their coronavirus task force, is going to roll out a national strategy. But can we wait until January 21st for that to happen? I simply think we cannot wait until January 21st. So I call on the CDC, I call on Congress to come up with a national strategy today. And the way to think about a national strategy is the way we have thought about, for example, you and I are involved in HIV. There is a national strategy for HIV. So think about a similar approach, right? And the approach on a national strategy requires a variety of different things. Number one, I think we need to have a very well-developed plan for testing. We need to have, Americans able to test and get results quickly. Lately, what I've been seeing is people getting tested and going back to waiting 4, 5, 6 days for a result. If you have to wait more than 24 hours for a result, the test is useless. We have to get testing, and we have to get testing into the hands of people rapidly. I think we need to have a better plan of how to use rapid tests so we can get results, especially rapid antigen tests. We need to have funding directed to do that. We need to have funding to the states to really do contact tracing. I think we failed as a nation in contact tracing. We're really not doing it well. I think we require a way to provide isolation for people. If you're diagnosed with COVID-19 and you cannot self-isolate at home because you live in a small apartment, you live in a small house with multiple other people, then you're going to transmit, and you cannot isolate. You're going to transmit to all those individuals. There ought to be a way for you to get a hotel room, someplace where you can stay for the next 10 days in order for you to prevent transmitting to others. And then we need to have a way to provide economic support for people. And Congress has been talking about the economic piece, and they haven't done anything yet. So we have to have a way to provide economic support to people at this very difficult time where, quite frankly, otherwise people continue to work, continue to do their activities because they simply have to put food on their table. They have to feed their children. They have to pay their rent. So we need really a national debate, and we need a national strategy now.
Wonderful. Thank you for that. I can't agree with you more. What kind of messaging are we going to need if the new administration comes in and puts forward a plan like this to make sure that we're all united in our approach to this?
You know, I think about the way we confronted many other calamities in the past, whether it was World War II, whether it was, 9/11. We came together as a nation. We came together as one nation confronting an enemy. We didn't say you're a Republican, you're a Democrat, you believe in this, you don't believe in that. And I think it's time for all of us to come together and realize that the enemy is not the mask, the enemy is not the liberals, the enemy is not public health, but the enemy is the virus. And we have to all work together to combat the virus. And we have increasingly better tools. The vaccine is one of them, but masking and other things. And I think if we all as a nation came together and really used our enormous capacity of compassion, of ingenuity, and of imagination to do the right thing, we can control this pandemic.
I love that. Compassion, creativity, ingenuity. That's what the United States has been known for. So we definitely need to do that. Let's turn for a moment to our children. Many public health officials support in-person learning, even though we do know that we need a national strategy and very strict guidelines for how we interact with each other. So what are your thoughts about in-person schools for children and balancing the risk benefit of that in the midst of spiking numbers?
Well, again, I go back to what I think is wrong with the way we've done things in our country. We have kept bars open and we have closed schools. I mean, let's think about what's important, right? I mean, we have to close bars and we have to open schools. Bars are where transmission is occurring. We know there's enough evidence right now to know that schools, especially for kids under the age of 10, is unlikely a place where transmission is occurring. And getting kids into schools not only is important for their education and their personal development, getting kids into school is critical for parents to be able to go to work. It's critical for parents to even work from home, let alone do anything else. So opening schools should be, again, not something we leave to the states or to the school districts to decide. It really has to be part of a national strategy. And we have had CDC put together some pretty good guidelines about what to do, but we need to get testing deployed to the schools. We need to get resources put at the schools in order to be able to do this. But schools should be our number one priority. We have to get schools open in order for kids to continue their education. Otherwise, I really worry about the long-term consequences of this very prolonged lack of interaction and lack of in-person education is going to have with young kids.
Yes, absolutely. Absolutely. Let's go back to vaccines for a moment. After this first wave of folks who are on the CDC list for priority for vaccination, where do you see it going next? And when do you think the vaccine might hit the general population?
Well, again, I'm going to go stop for a second and talk about what I see as a problem. The CDC Advisory Committee on Immunizations is making recommendations, but at the end of the day, it's up to the states to decide what to do and how to implement it. And they can decide whether they're going to indeed agree with CDC or not agree with CDC. I personally think that's wrong. We need to have a national strategy to roll out these vaccines. Imagine if state X says, okay, yes, we will vaccinate healthcare workers first, and we'll vaccinate, residents of long-term care facilities first. But there's another state that says, no, wait a second. We need a lot of our resources come from football. So we're going to vaccinate all the college students and football players first, so we can keep football going, because that's where we get our resources. They can certainly do that. And I think it's really wrong if we allow that to happen. We have to have a national strategy. We need to be sure that vaccines are given not only with equity, but with health equity in mind. We have to remember that the most affected populations have been African Americans, have been Hispanics. So I would say that a major priority is to try to get vaccines to those in most need. And again, I emphasize this: vaccines decrease severe disease and decrease mortality. And therefore, vaccinating our Black and brown populations is going to be, in my mind, an immediate need that we probably need to do in our second or third phase. Health equity has to be the driving force of how we think about using these vaccines.
Wonderful. Thank you for that. So let's talk about that. How are we, what's our best strategy to get vaccines to populations that have inherent medical mistrust based on generations of abuse in the system? And how do we need to communicate the safety of this vaccine and the accessibility of this vaccine?
Well, we first have to do two things. We have to get the data first to you, to me, to the scientists. Up to now, all the results from the vaccine studies that we've seen have been in press releases. I want to see data in order to be able to feel confident and to be able to communicate most effectively. What I've seen up to now shows very clearly that the vaccine is not only effective, but it's very safe. Now, when I say very safe, it means that it doesn't have major side effects, but it's a vaccine that does have some reactogenicity. And what I mean by reactogenicity means that when you get the vaccine, especially after you get the second dose, you have about a day or two that you don't feel well. You have fatigue, you have malaise, you have fever, you have headache. And a lot of people are going to say, oh my God, maybe I'm getting COVID. You don't have respiratory symptoms, and that's a key component. You certainly don't lose your smell, you don't lose your taste, but you do feel bad. And if you have, if you had the flu shot and it gives you a little pain, and if you ever had the shingles vaccine that you really feel bad for a day, these vaccines are somewhere in the middle. They're not as bad as the shingles vaccine, but there's not as benign as a flu shot. So the first thing we need to do is be able to communicate effectively that there is going to be reactogenicity, and that reactogenicity is good. That means the vaccine is working. You are reacting to it. Then we're going to have to work with communities. We're going to have to work with religious leaders. We're going to have to work with community leaders, because the most effective way for somebody in a community to get a vaccine is not because I tell them, it's not because you tell them, it's because somebody in their community gets a vaccine and tells them it's okay to use it. So working at the community level and partnering community is going to be critical to make this not a top-down program, but a bottom-up program. Now, what I see as a possibility is that people may decide not to get vaccinated, and therefore we will continue to see deaths and we will continue to see disease happening. So I think we also need to be very proactive, and we need to use geospatial mapping and say, in this community, in this zip code, there's a lot of disease, there's a lot of mortality. So how do we go there? Not wait for them to come to the healthcare system or them to come to the vaccination site, but we got to get vaccines to the community, to the homes, to the individuals where they are, so we make vaccination access easy, affordable. I mean, the vaccine has to be free, right, and accessible. So getting vaccines to people at their homes, in my mind, will be the most effective way of doing this.
Okay, great. And so we also want to remind everyone watching that the vaccine is going to require 2 doses, and they, for the current 2 vaccines that are under FDA review, that's about 28 days apart. Can you talk about when we think someone will have their full response to it after that second dose? Is it 2 weeks after, 3 weeks after?
It's interesting. The preliminary data that I've seen from one of the vaccines is that you actually have pretty good antibody response even after the first dose. So the second dose is almost like a booster.
Okay.
So, I would say that that probably 2 to 3 weeks after your first dose, before you get your second dose, you already have a significant response that actually gives you some degree of protection. So they're amazing vaccines. They actually, the efficacy is just blows my mind how good they appear to be. And I would say that, I mean, I'll be in line to get a vaccine as soon as I can. I really cannot wait for that to get my hands on a vaccine.
Yes, me too. I can't wait for it as well. And let's talk for a moment about different strains of COVID-19. We know, every year there are different strains of the flu. Are there also different strains of COVID-19, and is that going to impact the vaccination at all?
I don't like to call it strains, because strains is a term that it's a little too broad. There's different, there has been some variants, some genetic variants of COVID-19 that have been identified with specific mutations that tend to predominate and then tend to disseminate more widely. Up to now, those mutations have not impacted the spike protein to a degree that will impact the immunogenicity and the ability of the vaccine to respond. The way I explain it to people is, think about the front door of your house. You painted it a different color, but you didn't change the lock, so the key still works. So as opposed to the flu, where the mutations are in the hemagglutinin protein, that actually is the way the virus binds to the receptor in the cell, the mutations that we've seen in COVID-19 do not do that. So up to this point, it appears that the vaccine is working regardless of which strain is circulating.
Okay, wonderful. Thank you for that. Okay, we're going to go back to vaccines and who is going to get it first. The healthcare industry is huge across the United States. Are states going to be deciding how many vaccine dosages go to each hospital, or is there going to be a priority, do you think, within healthcare workers, those with more access to COVID-19 patients? What do you think is going to happen with that?
Well, I think several things are going to happen. Yes, I think states are going to decide how they divvy them out across the healthcare system. But at the healthcare system level, healthcare systems are always going to have to decide. And I'll tell you something very quickly. For example, because of the reactogenicity that I mentioned, you certainly don't want to go to your intensive care unit and say, okay, we're going to vaccinate everybody today. Because guess what? A good bunch of them are going to miss work for a couple of days because of reactogenicity. So you actually need to be very strategic in how you do this. And maybe you do it alphabetically. Maybe you do it by age. Maybe you say, we'll start vaccinating those that are over the age of 60. I mean, there's got to be a way to think about it in a very educated way. And you also have to go with your most at-risk individuals within the healthcare system. We know nurses are at significant risk. We know people working in ICUs and emergency rooms, respiratory therapists. So you may decide to vaccinate them before you vaccinate, for example, radiologists or pathologists or public health doctors, right? I mean, I think you need to really think about how you do this strategically, because you're absolutely right. By the end of December, we're probably going to have about 40 million to 50 million doses out there, which means be able to vaccinate about 25 million Americans. There's close to 120, close to 70 million Americans working in healthcare in some sort of way. So you're not going to have enough to vaccinate everybody.
Right, absolutely. Do you think we're going to end up with vaccine cards as a way to try to keep track of who's had the first dose and the second dose and which vaccine you've had?
I think there's going to be something, whether it's a card, whether it's an app, whether it's something in the web. Years ago, talking to Dr. Fauci, who you and I know it's a godsend to public health, and
Yes.
quite frankly, I considered Bill Fauci the sort of the high priest of public health. We were talking about how you vaccinate, and he's got a lot of experience from smallpox and other places. And we were saying, how do you go to a place in rural Africa and know if a kid has been vaccinated? And he said, couldn't we have a cell phone app that you just take a retinal scan of that kid, and up in the cloud, you can rapidly connect to a server that tells you this is the vaccines that kid has gotten based on the retinal scan. So something like that needs to be developed. We need to be able to have not a card, but something that it's a unique identifier, like a retinal scan or a finger, print, or something that says this person has been vaccinated with this vaccine and this date. And first of all, because then you can track who needs to be revaccinated, but also you need to be sure that if you got the Moderna vaccine, your second dose is not with the AstraZeneca vaccine.
Right, exactly. I know the vaccine has been tested in adults only, and we have one vaccine candidate that is going to start doing some of their clinical trials in children. How about nursing mothers? Have they been included in any of the trials that you know about?
Up to this point, I'm not aware of any trial that has included pregnant women or nursing mothers. There may be some women that got pregnant during the study,
Mm-hmm.
but even if they got pregnant, they're not going to be out there 9 months in order to know if they've been nursing. So there's desperately need for data in pregnant women, in nursing women, and in children. All the trials have up to this point have enrolled individuals over the age of 12.
Okay, great. And as far as you know, those pediatric trials are coming.
Yes, they are. In fact, the Emory Children's Center, Dr. Evan Anderson, will be starting one pretty soon.
Okay, fantastic. Is there any reason to believe that the vaccine will work differently in children compared to adults?
I don't think there's any difference to believe. The biggest concern that we all had is that the vaccine was not going to work as well in older individuals. We know that most vaccines don't work as well in older individuals, but from the preliminary data we looked at and from the studies that have been done thus far, the immune response in older individuals appears to be as robust as in younger individuals. Now, we don't know if that's going to last as long, but that's part of what needs to happen. And that's the other point that we need to say. You know, the data we have with the vaccines right now is enough to start giving an EUA and it's enough to start using it. But we're still going to follow the trial participants for the next 2 years because we need to know. A lot of questions people are asking is, do I need a second dose? How long does the immunity last? All those questions we don't know the answer to. And it may be, well, that a year from now we say, you know, gee, you need to get another dose of the vaccine.
Right. Now, the vaccines, as you've mentioned, superior to what we anticipated. We were hoping for 50 to 60% effectiveness, and we are seeing upwards of 90% according to the press release data that you and I have seen. Is there any reason to expect that when the vaccines get rolled out into the general population, that effectiveness or efficacy will decrease below the 90% threshold when we're back in the real world situations?
You know, I don't see any reason of why that will be the case, but there are some questions that people are asking. I mean, if I'm in an immunosuppressant drug, if I have cancer, if I have HIV, will I respond the same? I don't know. Those are questions that we need to ask, and that's why a lot of vaccine manufacturers and investigators are starting to move from what we call phase 3 to a phase 4 studies. We need to still understand what happens when you roll out the vaccine to the general population and not to the very cherry-picked, very specific clinical trials participants.
Okay. Last question for you today. Do you think high-profile individuals in the United States getting vaccines on TV will be a useful way to show the safety and their trust in the system?
You know, I think so. I was very happy to see this morning on Twitter, and maybe you saw it, that, you know, Presidents Obama, Clinton, and Bush together say we're going to get the vaccine and we're going to make it public so people, you know, see that we got the vaccine. I personally am going to get the vaccine, get my photo and put it on Twitter. I think we all need to do that. I think we need to, high-profile individuals need to really be out there saying, get the vaccine, you know, use it, it's safe, and be putting the example. But that example is going to be important, but it's not going to be sufficient. We also have to work with trusted community leaders. And we know from vaccination that at the end of the day, the most trusted voice in making medical decisions like vaccines is your primary care provider. So if you go to your doctor and your doctor says, oh, I'm not sure I would do this, you're not going to do it. But if your primary care doctor says, you know, yes, I believe in the vaccine, I use the vaccine, I put it myself, and I'm going to, in my office, we give the vaccine and we recommend it to all our patients, you're more likely to do it. So we also need to work with primary care clinicians to get them to work with their patients and their communities about increasing vaccine uptake.
Wonderful. Thank you. And one more question. I promised that was the last, but I've got one more for you. Can people get COVID-19 a second time?
You know, reinfection is something that it happens, but I would also say it's a rare event. There's documented in the literature, there's maybe less than 50 cases, and we got, you know, several million worldwide. So could you be able to get it in 2 years and 3 years? Maybe, but it appears that most individuals that have had it have immunity and have at least some degree of protection.
Wonderful. Thank you. As we've talked about a bunch today, the numbers are not good in the United States. There are some very positive things coming our way. Dr. Carlos Del Rio has called for a national strategy and for us to be coordinated and creative and compassionate in our approach to these COVID-19 numbers. So we urge you all to please stay socially distanced, continue to wear your mask, wash your hands, be good members of your communities, and take care of each other. Thank you so much, Dr. Del Rio, for being with me today. And thank you everyone for watching.
Thank you so much.